Welcome to this video on pneumonia in children. This video is brought to you by Dr. Sudath Abhay Wickrama. Our learning objectives are to define pneumonia, understand its epidemiology, recognize clinical features, assess severity, manage appropriately, and identify complications. Pneumonia is an infection of the lung parenchyma leading to inflammation, alveolar filling, and impaired gas exchange. Pneumonia is a common childhood illness, a major cause of mortality, and a frequent reason for hospital admission. It is a mostly preventable disease. Interventions like immunization, nutrition, and clean air are key for prevention. Risk factors include malnutrition and indoor air pollution. Limited access to healthcare and lower vaccination coverage for pneumococcal, Hib, measles, and pertussis vaccines also contribute significantly. Other risk factors include no breastfeeding, malnutrition, household air pollution, overcrowding, and incomplete vaccination. These are modifiable causes, emphasizing pneumonia as a public health concern. Globally, pneumonia accounts for around 700,000 deaths annually in low and middle-income countries, responsible for approximately 54% of all under 5 deaths. This contrasts sharply with high-income countries. Children in sub-Saharan Africa or South Asia are roughly 19 to 20 times more likely to die from pneumonia. Etiology is most commonly viral, accounting for 60 to 70% of cases. Bacterial infections account for 15 to 25%, and atypical bacteria for 10 to 20%. The most common pathogens vary by age group, with group B strep for neonates and RSV for infants. Before discussing pathophysiology, here is a quick reminder of the anatomy of the bronchopulmonary segments and a chest X-ray image for reference. Pneumonia pathophysiology begins when a pathogen enters the alveoli, triggering an immune response and cytokine release. This causes alveolar filling with exudate, replacing air. The key outcome is V/Q mismatch, leading to hypoxia and hypoxemia. Pneumonia presents as either lobar pneumonia, common in older children with homogeneous consolidation and typically bacterial, or bronchopneumonia, found in younger children with patchy consolidation centered around bronchioles. Clinical features include fever due to cytokines, cough from airway irritation, tachypnea from hypoxia and acidosis, chest indrawing due to reduced compliance, and grunting as an attempt to maintain PEEP. Diagnosis involves recognizing fever, cough, and a high respiratory rate. The WHO provides age-specific tachypnea thresholds. Severe signs like increased work of breathing, vocal crackles, or SpO2 less than 92% require admission and oxygen. Lethargy, cyanosis, grunting, and head bobbing indicate severe pneumonia. Female community health workers in Nepal have successfully managed childhood pneumonia at the community level using oral antibiotics. This community-based approach decreased under 5 mortality by 28%, demonstrating the impact of such interventions. For investigations, respiratory rate and SpO2 are essential, though imaging may not always be needed. If admitted, full blood count, CRP, and blood culture are important. A chest X-ray may be used for diagnosis or to check for effusion or pneumothorax. Viral isolation and lung ultrasound may also be performed in certain settings. This chest X-ray shows lobar pneumonia with dense consolidation in the right upper lobe. Signs of collapse are evident due to the elevated position of the horizontal fissure, and air bronchograms are visible within the consolidation. Round pneumonia, most commonly caused by Streptococcus pneumonia, primarily affects children under 8 to 12 years. Due to immature lung structures, the infection expands like a balloon. A chest X-ray must be repeated after 2 to 4 weeks to confirm resolution, or a CECT may be needed to rule out complications or other conditions. The silhouette sign refers to the loss of the normal outline of a structure on a chest X-ray. It denotes the loss of a silhouette and can also be called the loss of outline sign. Management involves assessing severity to determine if outpatient, inpatient, or ICU care is needed. Supportive care includes oxygen if SpO2 is less than 92%, maintaining hydration, antipyretics, and feeding support. Antibiotic choices are empirical, age-based, and guided by local policies. Slow-resolving or non-resolving pneumonia is defined as the persistence of symptoms or radiological findings beyond expected recovery. Causes of non-resolution include inadequate antibiotic use, resistant organisms, complications like empyema, and underlying conditions such as foreign body, TB, congenital lung disease, or immunodeficiency. Clinically, complications are signaled by persistent fever, worsening respiratory distress, or failure to improve. Local complications include parapneumonic effusion, empyema, and lung abscess. Systemic complications can involve sepsis, septic shock, and respiratory failure. Key takeaways include that pneumonia is highly preventable. Early diagnosis and antibiotics save lives. Age is a key factor in determining the likely organism, and tachypnea is the most reliable sign. Always watch for complications if there is no improvement. Thank you for watching this video on pneumonia in children.